Hey, welcome back, Bio30. We spoke a little bit before about that human respiratory system. We looked at how the system functions, but we haven't talked about any of the organs or the flow of air through this respiratory tract. So that's what we're going to do today, and then maybe finish up with a couple of disorders at the very end. So we're talking specifically about our respiratory system, the human respiratory system. And this is going to start at your nose and it's going to start to spread out later on in your lungs, at the very ends and tips of your lungs. Um, Other organisms have a respiratory system as well. It's probably not as sophisticated as ours is. Ours is phenomenal at doing what it's supposed to do. So we're going to look at every single component if possible. Here I've got an image of the whole respiratory system. You can see that we start in the nasal passage. It does also connect to your mouth, your oral cavity, but we're going to say the nasal passage is part of the respiratory system. Falls into the back of your throat, which is your pharynx, and then through the glottis, which is going to come into um, your trachea. So your trachea is your windpipe, and then going to split off into both of your lungs, where there are various other features that are going to help us with this gas exchange. So it looks like a very small, short system, but it is very detailed. It has um, a lot of phenomenal pieces. It's almost hard to believe that our body functions or creates itself in this way, but that is the way that it is. And I'm very happy. And I think we should all be very happy that we have this fortunate system that works in the way that it does. So let's start at the very beginning. Let's start at that nasal passageway and try to understand what's going on up at the very beginning. As I mentioned, you can breathe from your mouth, and you probably do from time to time, maybe more often than not. But the nose is where the air is supposed to go because we have a whole bunch of other features built into our nose that helps with the airflow. For one, we have a bunch of little holes or little gaps and turns inside of the nose from cartilage and bones that causes turbulence of the air coming into your nose. If you're not aware of turbulence, that's when the air is moving in multiple directions. We're forcing that to happen inside of our nasal cavity. This is so that, or the nasal passage, this is so that the molecules in the air are going to collide with each other. That increases that energy from collision theory. It's a little bit of chemistry there. That increases the temperature, which is useful to us. In addition, we have a network of blood vessels that are flowing throughout the inside of our nose. That's why you get nosebleeds. But these blood vessels are going to warm up that air so that when the air does pass through your nose before it gets into your body, it's going to be closer to body temperature. So you don't have to worry about this dry, cold air. You end up getting this ideally warmer, maybe more moisture retaining warm air instead. And that's more soothing, that's more useful for your body. Um, if you're outside in the winter in our Manitoba winters, it's very cold out, so you end up with cold, dry air. And when you breathe from your mouth, you realize that your throat gets dry very fast. But if you're able to breathe from your nose, it might hurt a little bit if that cold air is too much for the blood vessels. But if it's not too cold, you're able to breathe with a little bit more comfort because of the way the nasal passageway is designed. On top of that, we've got mucus and hairs all throughout our nose. Those are there to trap and block pathogens, whereas we don't have that same protection in our mouth. So when you're breathing airborne particles, it's better to block them with your nose. Don't change the way that you're breathing, though. Breathe however you are. Just realize that that nose is a useful piece if you're able to take advantage of it. This brings us to our upper respiratory tract. That air is going to end up into your throat, which we call the pharynx. And the pharynx is going to help that air travel down further into your body. Now, it can go into a couple of different places, either your esophagus, which is your food pipe. That's probably not where we want our gases to go. We want those to go into our respiratory system. So there's this glottis, which is opening and can be closed by the epiglottis. The epiglottis closes up the glottis so that the air is going to just be going into our trachea, and the epiglottis blocks the food from going into that windpipe. You don't want solids, you don't want liquids in your windpipe if possible. Not if possible, you just don't want them in there. If it happens, you cough them up anyways. A couple of other places where that air is going to pass through, one in particular is called your larynx, which is the very top of this very top of this windpipe. This is your voice box, so that's where you get the sound that you're making, or the sound that you're hearing from me is coming from my larynx. You have one as well. We're going to talk about that shortly. And then we go into the lower part of your respiratory tract, getting into your lungs. We're going to start off with that nasal passageway and then into this larynx. The larynx is the voice box. A couple of flaps of cartilaginous skin. So They vibrate when the air passes through, and that gives you the voices that you have. If you have a thicker larynx, you might have a deeper sounding voice. If you have a softer larynx, you might have a softer or quieter sounding voice. Quite often in men, it is a thicker structure. In women, it's a softer structure, but that can still fluctuate depending on who you are and depends on how you use it. You might be a voice actor genius, someone who's really good with voices. You have very good control over your larynx and the flow of air through that cavity in your throat. Or you might be someone who sings a lot, so you have a lot of experience changing the speed, the flow, the depth of air that's moving past, and even the structure of that larynx changes. So you can hit high notes, low notes. Whereas someone like me who doesn't have that practice cannot hit low notes, cannot hit high notes. I'm monotonous for a reason. After we get past that larynx, we get into your actual windpipe. This is called your trachea. It looks like a bony structure on the front of your throat. You probably don't want to touch it too hard because it does get sore if you do so. It's got a lot of cartilage that surrounds it. And this trachea will split into two trunks, these two large branches, I should say, and these are called bronchi. Singular is bronchus. Those are going to split into a pleural membrane, which is surrounding your lungs. And this is where the gas exchange is going to happen. Each of those bronchi are going to split even further into smaller bronchioles. So just like our blood system, we had our arteries splitting into arterioles. Our respiratory system has bronchi splitting into bronchioles. And those bronchioles terminate at these little grape-like sacs called alveoli. Each individual alveolus is just a pocket, it's a sac, which can hold that air. It's very moist, so it's a fantastic environment for that gas exchange to happen. The alveoli themselves, there's probably close to 1 billion of them in your body, and they have their own dedicated blood supply. So you can see on the image here, we've got a network of blood vessels surrounding. I got a better image coming up in just a second here, so I'll show that to you in a moment. Each of your bronchial ends are going to have a bunch of these alveoli. They look like grapes. This is so that you get a cluster, you end up getting this higher surface area. In the same way that the villi give you high surface area inside of your small intestines, you get this with your bronchi and alveolar structure as well. So here we go. Here's that image. You can see that blood supply at the very top. They're just capillaries. So you end up having this high concentration of oxygen in your alveoli, low concentration in your deoxygenated blood. This is the blue blood up here. Not actually blue, but you know what I mean. Because you have a high concentration inside, low concentration in the blood vessels, things move from high to low. We end up transferring that oxygen into our blood. It's already halfway dissolved because it's in such a moist environment. Opposite is also true with carbon dioxide, which is high in oxygen poor blood. So that's going to be diffusing into your alveolar structure so that you can breathe that out later on. Another image so you can see what that looks like here. And even if we had a micrograph or a better description of what that looks like, you'll notice that if we're looking at lung tissue versus muscle tissue, the process is pretty much the same, whether it's internal or external respiration. Here on the left, I have external respiration. This is your lung tissue and your blood vessels. On the right side, we have internal respiration. The muscle cells are darker, but they do the exact same thing. So they function the same way. They're just connecting two different environments. When we transport these gases, most of the oxygen that we're trying to transport gets hooked onto hemoglobin, which is that special protein we talked about before. Hemoglobin latches onto most of the oxygen in our body, but it can also latch onto a little bit of carbon dioxide. So we can use hemoglobin to remove carbon dioxide as a waste product. Really, though, that carbon dioxide goes to a number of places to get left out of our body. Often into your integumentary system, it can be leaving through your excretory systems. You might pee it out. It might go into your digestive systems. You might poop it out. Lots of places that this carbon dioxide ends up in. We can even use it for other reactions in our body. So it doesn't all come out of your body, just like almost all the oxygen comes in. Sometimes you have a lot of carbon dioxide still in your body, but that has to go elsewhere in your body. That brings us to a couple of disorders. We're going to talk about all of these in brief, starting off with tonsillitis. This is where your tonsils become inflamed. It's a really annoying situation because your tonsils are kind of not really useful. They can get infected, they get inflamed, and quite often, if that's the case, it might be useful to just have them removed because they don't really do much for us anyways. If you do ever have tonsillitis, you get like a sore throat. It's harder to breathe through your mouth. It's just really annoying, honestly. And because you don't really need them, a common procedure is to remove them so you never get tonsillitis again. If you have your tonsils and you've never had tonsillitis, you don't have to rush to the hospital and get them removed. You might never experience it, but it's just an annoying one if you have it. If you have them removed, though, you can't get tonsillitis. Laryngitis, on the other hand, this is something that all of us are going to experience at some point in time. So, laryngitis is when your vocal cords end up becoming a little bit stressed out, either from overuse or misuse. Quite often, if you're talking a lot or teaching a lot, if you went to a concert or if you went to a hockey game and you just cheered your heart out, you might notice that afterwards your voices might maybe a bit raspy. If you went to a festival at the end of the week, you might try to talk and you hear nothing coming out for your voice. It's because your vocal cords have been inflamed. The good news is give it a couple of days and laryngitis clears up pretty well. Like it's pretty quick to clear up. So it's just one of those things. They stress out, they calm down after a while. Pneumonia, on the other hand, this is when you get inflammation and fluid buildup inside of your lungs. A couple of different ways that this can happen. You either get it through a bacterial infection. Quite often that happens in a lobe, so you end up getting lobular pneumonia. You can also get bronchial pneumonia. This is when you get maybe a viral infection. Some common viruses can cause this to happen. So, influenza, for instance, you can get pneumonia from getting the flu. This is why it's good to get your flu shot because that's going to prevent the pneumonia causing influenza virus. You still can catch the flu, but you're less likely to get pneumonia from the flu in this situation. So I clicked away there for a second. Another one that you might experience, kind of annoying if you get it, is bronchitis. It is a chronic situation, chronic obstructive pulmonary disease because it's an illness, pulmonary because it's your pulmonary circuit or your system, and obstructive because it's blocking the airflow in your bronchi. That's because there is mucus forming on the inside and your airways are becoming inflamed. Really annoying because you can't cure it. If you ever end up with bronchitis, we can either give you some medications to manage it, or you can work on your diet or substance abuse. Quite often, if you have bronchitis, it's because there's something else in your body that shouldn't be there. Very often, it's smoke. Smoke are solid particles suspended in air, which should not ever be in your lungs or respiratory system. So that causes you to not function as well. So there are a couple of programs out there to manage COPD. Asthma, on the other hand, same idea. It can be managed. We can't really cure it. This is when your airways get swollen or inflamed. When a person is having an asthmatic attack, you might notice that they're wheezing a bit. That's because their airways are very thin, so the air is barely flowing through. And so it sounds like they're almost whistling as they breathe. The good news is we can manage it, and it's very easy to manage. Quite often, an asthmatic patient will have an inhaler, typically a blue one that's Ventolin. Ventolin is a beta blocker, so within 30 seconds to a minute, that patient will have sort of alleviated symptoms. They're able to breathe again and back to normal. Whereas on the other hand, you might have a situation of a very severe type of asthma where you'll use Advair, the purple inhaler instead, and that's a more fast-acting inhaler where it activates right away, right on site. So within 30 seconds, that person's airways should clear up. There are other inhalers out there, but to be totally honest, I don't remember, and I haven't looked up. I told the other groups I would look up. I haven't looked them up yet, so we can look up the orange and the green ones at a different time. One situation that will catch up to all of us eventually is emphysema. This is where your alveoli start to lose their elasticity. Happens over age. If you're a healthy person, you work out regularly, it won't happen until much later in life. However, if you're not so much that kind of person, you're more sedentary, then maybe late into your 50s, early 60s, you might start to experience some difficulty breathing. That's because you've lost that elasticity, so you can't breathe as easily anymore. But you're still breathing. So that's why an older person might be breathing more heavily while standing next to you. They have a case of emphysema in this case. This can be caused by various irritants getting into your system. Again, we can manage this either by giving a person a high concentration oxygen, or sometimes some inhalers are useful as well to help us out. Something that we can't work with, though, is cystic fibrosis, genetic condition where you get some fluid buildup in your bronchi and bronchioles. Quite often, it is a mucus, and it's a very sticky, thick mucus. So if you were to cough it up, you end up seeing this green, sludgy material. Hard to cough it up, though, because it's very thick and it's very sticky, so it's really hard to move it. If it's there, you can get some bacteria stuck in them, and then it causes infections. Terrible situation. Because in your lungs as well, we can't just give you a pill to heal you, because when you give you a pill, it goes into your digestive system. So we have to give you some other sort of medication, maybe some sort of inhaler, and this is going to hopefully dissipate, break down that mucus, thin it out a little bit. That's the best we can do to relieve symptoms. We can't actually cure cystic fibrosis. The last one I want to show you is another one we can't cure. It's not a great one. It's probably the worst one. This is uncontrolled cell division, where you have a carcinoma or a tumor growing in one of your lungs. Sometimes those tumors get so large that they end up metastasing. So they move from one place to another. They break off essentially, you end up from one tumor to two. Terrible form of cancer because, again, it is in your respiratory system. It's a hard track to get into, so we can't do much about it. So you have a lot of coughing, a lot of chest pain, hard time breathing. You lose your appetite because your body's focusing on the cancer instead. The sad news is that if a person gets lung cancer, it's so hard to deal with that most people don't end up surviving it. So we like to avoid these situations. If we're keeping just airflow inside of your lungs instead of particulate matter, so avoiding smokes, not just cigarettes, but things like marijuana or secondhand smoke or pollution, or having a mask on when you're living or working in a country that has poor air quality, you're reducing the odds of these carcinogens getting into your lungs, and it reduces the odds of getting lung cancer. That way you can avoid it altogether. You don't have to end up dealing with it. Anywho, that brings us to the end of our respiratory system. So hopefully we learned a couple of things about illnesses and the tract itself. I'm going to leave you here for the time being, and we'll see if we can pick this up a little bit later on our next body system. Until then, though, I will see you later. Have a good one, Bio30.